Okay. Hello, everybody. Welcome. Here we are, early February, and welcome to those who are here live with us, and welcome to those who are watching on YouTube. We are so lucky to be here with Glenn Grossman, who is our esteemed epidemiologist who has been our tour guide. I can't believe yesterday I read about the grim milestone that we passed on February 6th. Last year was the first recorded death. Patricia Dowd passed away. So I wanted to just take a moment to remember her and the over 450,000 people that we've since lost. And even Glenn, according to your statistics, the way may even be way more than that. And may all of their memories be for a blessing. And Glenn, you are certainly a blessing. I've always known that, and now we know that even more. You're sharing your over 20 years of experience in epidemiology with us this past year, and into who knows, however long this goes on. We are eternally grateful. As many of us know, while pursuing your doctorate in epidemiology at UNC Chapel Hill, you served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. Glenn has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, the Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. So Glenn, here we are, over a year into this. Where are we? How are things looking?
Yeah, so as expected, let me share my screen. Things are going in the better direction. And thank you, Becky, for the introduction. Thanks to everyone for joining. It's great to be here with you on this snowy day in New Jersey, Super Bowl Sunday. Maybe we'll talk about that a little bit if we have time today. But let me share my screen. All right, so we're continuing on this downward trend that we've seen for a while now, for many weeks. I think it's been almost a month. So we're looking at January 12th, and it's now February 6th, February 7th rather. And so it's 3 weeks or so that we've continued this downward trend. The hospitalizations have been going down, which is really great. The hospitalizations have been sort of the key worry that we've had, because if you fill up the hospital beds, then you start having even more deaths, because then people who don't have COVID but have heart attacks or strokes or other emergencies, there's not enough beds to treat even them, and then you have sort of this synergy and this terrible synergy in terms of more morbidity and mortality than just from the disease alone. But luckily, in most hospitals, we haven't reached that point. Interestingly, in Brazil, they have reached that point. So they had the first surge that was really bad in Brazil, and then the new variant arose. And the new variant arose and spread like crazy in Brazil, and became the most dominant strain within around a month in some cities. And there were so many people flooding the hospitals over the last couple of months, over the last month or two, that they've run out of oxygen and even like basic supplies. And once you start running out of such basic supplies, then forget about COVID. Anyone else who comes into the hospital who has a heart attack or any other serious injury, if there's no oxygen for them, then it puts their likelihood of dying much, much higher. So Brazil is in much, much worse shape right now. And so we can talk about that variant a little bit later today. But in terms of the United States, we see the hospitalizations are going far down. The death rate is staying roughly the same. Typically, we expect around a 14-day lag between the rise in the cases and hospitalizations versus the change in the death rate. So when we saw in previous periods, there was typically a sharp rise, and then the fall was typically much slower over time. But in contrast, in this, we're seeing a pretty rapid fall. And that's because we had these triple events in the winter that really helped this to spread. One was Thanksgiving, then that was followed by Christmas, and then that was followed by New Year's Eve. And together, those three things just kept on increasing the spread, increasing the spread. After that, people have mostly, there's not been any major event since then. And so people have been mostly staying at home. And you can see what happens when people stay at home and don't spread the disease as much, that it rapidly falls. And so it's good that it's rapidly falling now. If we had had this back in October, had similar amounts of restrictions, now a lot of it's natural. People are just staying at home in general after the holidays. But if we'd done this in October, then we would never have seen such large peaks that we had. This is across the board. So when you look at the state by state level, this graph is showing us the week in which each state had their peak. You can see that Hawaii had its peak back in August, and then the last state that had its highest peak was back in January 17th, and that was Virginia. And so you can see that we've gotten way past, this is across the United States, so that we've improved dramatically. When you look at the hospitalization rates, which is the next important thing, per million. So we can see here that the big hotspots that are currently being hit are, so New York is being hit pretty hard. Arizona is still being hit pretty hard. New Jersey is being hit pretty hard. But a lot of other states have are going way down. It's hard to see on this a little bit in terms of some of the states, but generally, proportionally, a lot of the states are doing much better. We're still not out of the woods yet, but we're doing much better than we were. And so it's going in the good direction. The two key things that we're looking at now are, I can compare to the United States to the world, but the two key things that we're looking at now are how quickly we can vaccinate people and how quickly the variants, the mutations are spreading. So if we look over here, I can get into the variants now. Whoops, let me go back up to this one.
Glenn, before you get into the variants,
yeah,
can you just remind us about the definitions? Can you define for us again the difference between mutations, variants, and strains?
Yeah, for sure. So a mutation, here, let me share my other screen. All right, so this is a good point. Let me see how quickly I can find this.
Sorry, I remember you defining this for us a few weeks ago, and I've been thinking about this when I watch the news, how these terms seem to be sort of interchangeable.
Yeah.
And I was thinking back to when you shared with us, in many ways they're not.
No, it's a really, really good question. And I'm glad I had a slide that I never used, and it's just been sitting here for a couple of months. And so I can bring it up. So basically the question is the difference between a mutation, a variant, and a strain. So now the genetic sequence of the SARS-CoV-2 is around 29,903 nucleotides. The nucleotide is the basic unit of information, and combinations of nucleotides make the genes within the genome, okay? Anytime one of these 29,903 nucleotides changes, that's a lot. This is almost 30,000 nucleotides. Anytime a single one of those change, it's called a mutation. And the changes can happen in three ways. Either it can be, one of the nucleotides could be deleted. So instead of 29,903, there's now 29,902. Or it could be mutated where there's an addition. So instead of 29,903, there's now 29,904. Or it can be replaced, where you had one nucleotide, so there's still 29,903, but you replace one. They make an important difference, because when you read a sentence, like essentially if you think of these nucleotides as sentences, if you replace a letter or delete a letter, it could change the whole meaning of the rest of the strand. And so even though the sentence mostly has the same meaning, by changing that one thing or eliminating a single letter, you can actually make a big difference in the shape of how you recognize it. It's the same as with English. If we're reading a sentence, if you were to delete one letter of a string of words, it might have a meaningful impact depending on the letter. Like, so for instance, if you said something was like not important versus it is important, like that one meaning could like flip the whole interpretation. So that's a mutation. A variant is when you have groups of mutations. And so instead of it being a single mutation, it's a whole bunch of different characteristics that have changed. And so over time, that looks like this. So one mutation might be just one little dot that's changed, but then when you have branches over time of a bunch of different mutations, then you can almost classify them. In fact, you can actually classify them into sort of these different, we call them variants, the different groups of mutations that sort of define, they have different, sometimes different behaviors based on how much they spread or how severe the disease is or other types of impact. And so it's the combination of mutations that are what we call a variant. Now, the difference between a variant and a strain is that all of these variants are essentially the same virus. They have just enough mutations to have slightly different behavior, but it's kind of like with dogs, how it's one species of dog, but there's lots and lots of different breeds. So you might have a golden retriever and you might have a poodle and all different kinds of breeds. They're all the same species of dog, but they're lots of different breeds. In this case, the variant is kind of like a breed. Now, the difference is with a strain, the strain, it's still the same species, but what happens is that they get different enough that they are meaningfully different, and you can't really even compare it as the same variant. So it's kind of like when we talk about the flu, where the flu one year might be one type of strain, and then the flu a different year could be a different kind of strain. And the reason the idea of strains are important is that once you have a variant that's different enough where it's no longer protected by our antibodies, then it's as if it's a whole new outbreak of something where there's no immune protection anymore. And that's why there's the difference between a variant and a strain is so important. Currently, with the UK variant, and even to a lesser degree, but still to a degree, the Brazil variant and the South Africa variant, there is still enough overlap that we have an antibody response to it. So they're still considered variants. But if there's much more drift in the mutations among the different variants, then it might escape completely. And instead of it being just a small variant, then we might be different enough that we need to think of it as a whole new animal in that sense, and that it's behaving differently. It's no longer controlled by our antibodies, and it's escaped and is now a new strain. Does that make sense?
Big time. Thank you. Very
Great.
helpful.
Sure. All right. So let me come back here. And so I was talking about the vaccines, I think. Well, yeah, let me talk about the vaccine because that's more interesting. So the question here for the vaccines. So the question is, how quickly are we vaccinating people? In the United States, where I'm most interested, Biden came into office on January 20th and claimed that within the first 100 days of office, when there would be 100 million doses of the vaccine that would be given out. And there's nothing he could really do within the first 2 days to influence the vaccine. And you can see based on the trend, we're already going to hit 100 million doses within 100 days, regardless of who was president within the first 100 days. So I like when we hear such good talk, but it was actually pretty conservative. The question now, in terms of evaluating Biden's behavior and how well he does, his success, is how well we can continue lifting up the curve. Because you're seeing that over the last week or so, we've sort of hit this plateau because it's really hard to continue ramping up. You sort of reach this diminishing returns in terms of just how much production capacity there is. So the big question is not where we are now. The big question is over the next few weeks, the next month or two, can we continue the trend up higher? Because this is we see that we've already hit this sort of this plateau over the last week in terms of what we're doing. We're still hitting over 1 million people a day, but it's not enough. We need to be doing a lot more. You can see how we compare relatively to other countries in the world. So currently, I wanted to look at cumulative. So in terms of cumulative doses, currently Israel is still well in the lead they've vaccinated over 62%. This was a day ago. So it's approximately 63% of the Israel population has received their first vaccine. Um, in United Arab Emirates, that's next, 43%. United Kingdom is it roughly 18%. UK, because of the UK variant, they need to urgently get their vaccines out. And so that they're really putting a lot of effort into it. The United States now hopefully will be putting more effort into it. We're currently at around 11, 12%. And so hopefully we'll be ramping up more. Europe is not doing nearly as well. They're starting to roll out, and they've been vaccinating for a while, but they're only at like 4 or 5%, depending on different parts of Europe. So it's very slow going in the world. You can see when you take a glance at the world, in terms of the percent of the population, we're really looking at like, so when you're looking at 1 to 3%, that's Canada. We're looking over at China. We're looking at India is at less than 1%. You can see that there's lots of parts of the world that are really not doing very well. Um, but we're getting there. This is going to be a big issue in terms of vaccination, because once we vaccinate the population in the United States, the big concern at that point is going to shift to the mutations and the variants. And so once most of the United States is vaccinated, then that means most of the mutations are going to be occurring outside of the United States. And so the only way to prevent those mutations from happening and getting into the United States is to get other countries vaccinated as much as we possibly can. So hopefully we're going to see a major effort by the World Health Organization partnering with the United States. Once the United States is vaccinated, or hopefully maybe even at the same time, hopefully there'll be a major push to vaccinate much of the rest of the world. Because if Brazil is still on fire in terms of how many cases there are, and other countries are going out of control, we need to get those countries under control too, not just for their sake, but for our sake, to prevent the mutations coming and other variants. So that's going to be a big push to get much of the world vaccinated. Um, in terms of, so let me see, in terms of where we're looking, I can just go back for a second. Amongst a lot of the big cases that we've seen, this phenomenon of us rising and then falling is something that's taken place all over the world. And this is just a natural consequence, because typically what happens when you have an outbreak at any one time, and we know it's been a seasonal outbreak in the United States, the numbers rise even with mask wearing and even with socially distancing and all the other things that we're doing. They rise until there's no more susceptible people, or not as many susceptible people under those conditions of isolation and mask wearing, whatever. And then as long as we keep up the same behaviors that are these healthy behaviors, then you're automatically going to expect a fall. As people start to not wear masks anymore and don't socially distance and whatever, then these numbers are going to start to go up again. So we need to keep doing what we're doing to get the numbers dropping further. United Kingdom is doing is dropping faster because their restrictions were more heavy. And that's another good point, is that the United Kingdom has the UK strain of the virus. It rather not strain, rather the variant of the virus. And so because of this, it is 50% more contagious in the United Kingdom. So the fact that they are dropping at a faster rate than the United States, even though their variant is 50% more contagious, means that it's really their lockdowns, it's their restrictions that's driving this more than anything else. It's not a attribute of the virus. It's an attribute of the government's decision, of the leadership in the government. The United States right now, the trend that we've seen is not really much to do. We've seen a lot of different states having different policies. They've had impact where they've been, but we've been too loose. But a lot of what we're seeing is just sort of a natural fall based on the overall guidance that we've been seeing without a huge amount of additional restrictions. All right. That's enough for this week in terms of US COVID and vaccine. The one thing I'd like to jump into are the variants here. And so in the United States, in fact, let me come back over here. So last week when I talked about the variants, the numbers that we were looking at were there were so B117 is the UK, the variant that's common in the UK. B1351 is the variant that's common in South Africa, and P1 is the variant that's common in Brazil. And so you can see that the UK variant, there were only 434 cases reported, but the reason that there's so few is that we're doing a really, really bad job at screening for the genetics. When people go and do a COVID test, it just comes back as positive or negative. We have very, very few tests that are actually screening the genes of each person's virus. And so my best estimate last week was that for every one reported case, it represented around 333 people in the United States with that. So that means if there are 434 cases, then that means it represented around 145,000 infected people in the United States with the UK variant. And so that's a lot of people around the United States. This week, so we were at 434. Look at these numbers: 434 for UK, 2 for South Africa, and 1 for Brazil. Now it's a week later. Now we have 611 UK. It's almost what is that? Almost 50% more of the UK variant in a single week. In the South Africa variant, it's jumped from 2 to 5, so it's doubled in that time. And the Brazil variant also, it's gone from 1 to 2, so it's doubled. And so now, if the frequency of the sample is the same, then that means that we've gone from an estimated 145,000 infected people to 204,000, 203,000 infected people in the United States. And so that's a lot. So this is a lot to keep track of. I think that after Biden came in, one of the first things that he's done is let me see if I can find it here. That is not it. One of the first things he's done is increase surveillance on the strains. So now there is a lot more genetic screening that's being done. I don't have a good estimate of how much is being done, so it makes it harder to estimate the total population of people in the United States who have the genetic variants that we're looking at, because I need to understand what the rate of screening is, and I'm not quite clear right now. We knew a couple of weeks ago what it was, and that's why I multiplied by 333, but now it's a little bit trickier to understand what it is. But so I'm keeping track of this. I'll report back in further weeks. There's a lot more screening being done. There are 2 mutations. So in addition to the variants, within the variants, there's 2 specific mutations that have become the most interesting ones right now. The first one is called D614G. And this seems to be one of the most important mutations that really makes the virus more contagious. And so people who have this variant tend to be 50% more contagious. So this one mutation becomes important. Now, because I was saying variants are lots of mutations, and the mutations all work together to influence their behavior, it's not only the D614G that's the important one for making it more contagious, but this is one of the most important ones. There's other ones that add to it and sort of make it synergistically even more contagious. That's the first mutation that we're tracking. The second mutation of worry is called E484, and E484K. E484K is interesting because this one mutation seems to reduce the effectiveness of the vaccine by something like 30 to 50%. And so that's why this mutation is so important. This mutation is the one that's the predominant one in South Africa and in Brazil. And it's this one mutation. There's other mutations at play too, but this one mutation seems to be the most important. And just as a brief aside, because I think it's just kind of interesting, how do these mutations get their names? So in this case, the mutation name, E484K, comes from the following reasons. The mutation comes from the position in the string of the RNA that occurs at number 484. So it's the position is 484. The letter E refers to the original amino acid that was at this location. It was originally glutamic acid. And K refers to the amino acid that is now in that location. It's replaced it. It's lysine. So E was removed and K was replaced in this one location. And so now it's totally clear what the code means in terms of a mutation. So we know how to interpret it going forward, what the mutation stands for. But so this E484K is something that's important to look for because of the vaccines, and the 614G is important. So now here, what we're looking at are some of the key comparisons. So the first, the UK variant, also called B117, has now spread to 70 countries. It's in the United States, and you can see it has the D614G, which is what's making it spread so much. It's around 50% increase in how contagious it is. The P1 variant is Brazil. Brazil also has the D614G. We haven't determined how contagious it is, but because it has the D614G, then that means that it's expected to also be spreading like crazy. And we know this in the real world because the UK variant took around 3 months to become the most common variant in the United Kingdom, whereas in Brazil, the Brazil variant became the dominant variant within a single month in Brazil. It spread that rapidly. And so D6146 is the primary reason for that. But Brazil is interesting because it also has the E484K that makes it more resistant to the vaccine. And similarly, the B1351, which is South Africa, also has the D614G, which makes it more contagious, and also has the E484K, which makes it vaccine resistant. Now, the worry is what happens, because UK is not just contagious because of the D614G, it's also contagious because some of the other elements it has in it, or some of the other mutations it has in it. Now, one thing that we were worried about is what if these variants were to merge, and what if, or what if the UK variant would mutate more to become more like the Brazil variant or the South Africa variant? Because right now the UK variant, which is so common, does not have the E484K. Unfortunately, UK has been tracking this, and unfortunately, they have now detected the E484K mutation in multiple people with the UK variant. So now the UK variant, in addition to having higher fatality and being higher level contagion, it also is increasingly resistant to the vaccines. Right now, it's extremely rare among the people who have it, but because it exists, it's very, very likely to now become more and more common. As people get the vaccine, then the vaccine is going to stop the production of people who are sensitive and susceptible to the vaccine, but the people who have the E484K mutation will be less susceptible to the vaccine. And as a result, the limited spread that will continue is likely to have more and more of a majority of the E484K mutation. And so this is what we'll see this in multiple places around the world. And as this starts spreading in the United States, we will begin to see this in the United States as well. I think that's
Len,
it.
this is just very quickly, very interesting how these different viruses get their names. And before we turn to questions from the audience, you made me stop and think, wow, all these different viruses and these different names. And it made me wonder, how did R2D2 get his name? Do you want me to share?
Oh, please do, because I don't have any idea.
Okay, so I did a quick search. Would you like me to share? Or
Please
is it totally
do.
off topic?
Oh, no, I'm really eager now. I don't have any idea.
Okay. The name derives from when Lucas was making one of his earlier films, American Graffiti. Sound editor Walter Murch stated that he is responsible for the utterance which sparked the name for the droid. Murch asked for the real 2 dialogue track 2 in the abbreviated form R2D2.
Wow.
Okay, back to the regularly scheduled program. Rachel, if I could ask you to unmute to take us through your question regarding the variants, please.
So quick question, and maybe it's not quick. Variants, mutations, and ultimately strains are they the natural part of the epidemiology of a disease or of a virus? And as we know more about SARS, we'll learn, I mean, our SARS-CoV-2, 19, whatever we're calling it these days, sorry, we'll see more and more of this information, or is this virus mutating or having variants at a different rate? Is it standard? Is this pretty predictive of what happens with epidemiology and a virus?
Yeah, that's a really good question. So, so this is typical of what happens with any virus. This is, but normally what's different is that normally this is something that epidemiologists would just be paying attention to behind our closed doors. We'd read about it in the medical journals, but no one who's not an epidemiologist would really care. Like most normal people wouldn't be paying much attention to it. But because we're in an epidemic, everyone is hungry to know as much epidemiology as they can. So that's why it's more common in the news and people are talking. In terms of the mutation rate, so there's two types of viruses. I would say 2.5 types of viruses. There is the first type of virus is a DNA virus. And a DNA virus is double-stranded. And because it's double-stranded, it tends to mutate much, much less because you have one reference strand. So when you're replicating one, it can always check to match to make sure that it's okay. So it doesn't mutate as much. RNA viruses, like the flu, like SARS-CoV-2, because it's only one strand, it's much easier to mutate. And that's why we have so many different strains of the flu circulating, because there's only one strand, it's extremely easy for the flu to just have tons and tons of mutations all the time. So it's constantly mutating, and that's why the flu is so crazy. What's unique about SARS-CoV-2 is that it has a built-in proofreader in the RNA and in its genetic code that it carries with it wherever it goes. And so when the SARS-CoV-2 replicates, it has this proofreader that goes through, even though it's a single strand. And so it tends to restrict the mutations very much. So even though it's an RNA virus, it doesn't mutate at nearly the rate as the flu does, but it does mutate a little bit faster than DNA viruses do because it doesn't have the reference. So this is something that was totally expected. The reason we're seeing so many mutations arise is not because the rate of mutation is higher, because the rate is still low. It's because so many millions of people are being infected, even if you have a very slow rate, just the fact, even if you have a very rare event, just the fact that you're throwing the dice so many times because so many millions of people are being infected, you're just likely to have an accumulation of mutations because of that. So I said there were 2.5 viruses. The third type, which is a lot of people don't really consider it to be a virus, but it acts in some ways that's similar, which is really interesting. So it's sort of, I consider it like quasi-virus at best. But so viruses, the two I said, DNA and RNA, use genes. It uses nucleic acids as the base. What's different is this third kind is we now know, we've known for a while now, that proteins can replicate and can change other proteins. So for instance, so these are called prions, and there's some diseases that have been identified. So for instance, you might have heard of mad cow disease. This is not actually a virus, but it's similar in some ways to a virus because what it is a protein like that makes muscle tissue, like protein, which isn't genes, but it's the protein itself goes in and it interacts with other proteins and then replicates and causes those proteins to reproduce itself, which is so fascinating. And so the fact that it's sort of not a bacteria, it behaves a little bit like a virus, but it's not nearly as sophisticated. It's sophisticated in its own way. For me, I consider like 2.5 types of viruses because it's just so fascinating. Anyway, I think I answered your question. So next question.
Thank you, Rachel. Thank you, Glenn. Okay, so thank you, Glenn, for explaining the difference between mutations, variants, strains, and taking us through what we're seeing abroad and across the country. Undoubtedly, in the next few weeks, you'll be sharing a lot more information as testing increases. I can only imagine what those numbers are going to look like. So we will stay tuned. Let's switch. Yeah, go ahead.
Before you continue, one thing I'll point out here is this. So when you look at the numbers that we have, so right now, there are 611 cases that have been identified with the UK variant. And so I'm estimating this represents maybe a couple 100,000 people infected, but it's a little bit unclear because I'm not sure what the sampling rate is right now based on after Biden has come in. We know that there's a little bit more testing. It's not exactly clear. But when you look at the total, and this is the total cumulative that have been identified in the United States so far. When you look over here at the total number of people, total number of people who are infected daily, we're still hitting over 125,000. So over the last couple of weeks, if there were 200,000 of those cases, but we've had a couple of million, and that's assuming that only a percentage of these are being classified, because there's a lot of people who get COVID-19 or are infected with SARS-CoV-2 who are not even diagnosed. So the cases are only a fraction of the total number infected. A lot of people could be asymptomatic, for instance. Of these, there were millions of people over the last week or two that have been infected. And so that means that it's not enough to be discernible in this data. It's just a very, very small percentage of these total that have one of these variants of interest, or sometimes we call it a VOC, a variant of concern you might start hearing about. And so as a result, even though the numbers are falling, at some point as the variant of concern starts to rise, then we might see it's going to stop falling so fast, and instead it's going to start to level off or possibly go up again. And so that's what we're going to be looking out for in the next month or two. I think we're expecting, a lot of people are thinking within the next 5 weeks to 16 weeks is when we're really going to start to see the emergence of any new behavior based on the variants of concern that are going to come out. So that's what we're going to be looking for in the next 6 to 16 weeks, 5 to 16 weeks. All right.
Thanks. Thank you for clarifying, Glenn. Harry has a question. Harry, I'm going to ask you to unmute, please.
Okay. So my question is, you seem to have a race going on by opposing forces. You've got the different strains coming on. You've got people being vaccinated on a basis that's increasing, but you also have a significant population of people that are opposed to being vaccinated, which is going to keep the whole system running for a very long time. So how do you foresee the next year with all these opposing forces in play?
Yeah, that is a really good question. Let me see. I normally go to a website. Let me come on here. There's 2 websites actually. Let me share my screen first of all.
Mute us back. What? Mute us back.
All right. All right, so one website that I've been going to is the Morning Consult, which does, it's been doing polls throughout the outbreak. And so let me see, they sometimes say vaccine hesitancy. Here it is. So currently 3 in 5 adults say they would get a coronavirus vaccine. So that means 2 in 5 adults are currently, so 40% currently say they would not get a vaccine. You can see that among, it's interesting that there's been wide variation among the different political parties. But interestingly, so the Democrats right now are increasing. Democrats are almost 80% likely to say that they'll get a vaccine. And so that's interesting. Whereas among Republicans and independents, they're at roughly, what is this, like 55%, 55% willing to get a vaccine. We also saw a market variation based on whether someone lives in an urban area, a suburban area, or a rural area. Makes a big difference, where urban and suburban people are far more likely to want a vaccine. We also see much variation based on race. So here you can see that whites, Hispanics, and other race or ethnicity are all clustered above here at roughly 60%, maybe 60 to 70%. But you can see a trend over time where it's slowly increasing. So the average in November was down at maybe 50%, but slowly increasing, so it's above 60% among them. Among Blacks, it's a lot less. And vaccine hesitancy now, so Blacks, it's roughly varying around 40 to 50% or so who say that they'll get it. But that's an improvement. It was closer to 30% back in November. Blacks, a lot of people might not be aware, but there was a long history of medical experimentation on Blacks in the United States very recently, even within just decades ago, just a few decades ago. And so one of the main things that people talk about is the Tuskegee experiments, where essentially some doctors were experimenting on patients who had syphilis, and the doctors wanted to see the long-term consequences of suffering from syphilis. And the problem was that there was a cure that became available during the study, because the study was supposed to last decades. And there was the cure, the penicillin, and the other cures became available during the study. I forget if penicillin was the actual treatment, but the cure became available. And the doctors, because they wanted to find out what the long-term consequences of the disease are, didn't tell their patients who were Black. And they just let their patients suffer for years. And the part of the consequence of developing syphilis over long term is it makes the patients have really severe disease consequences, long-term permanent consequences in terms of infertility and other major consequences, deformities of different kinds. And as a result, from this and other experiments like this, the Black community in the United States is legitimately, or has been legitimately, terrified of the medical community targeting them for medical experimentation where they just can't be trusted because of this. And there is this record. This is not something that happened 100 years ago or 60 years ago. This happened recently. Although maybe this was like 1960s, I think, was Tuskegee, or somewhere around that time period. And so because of that, there is a real issue here, and it requires special outreach because of this long history of racism in medicine among African Americans. So there is this variation there. However, it is improving. One thing that you'll have noticed, the Trump administration, the previous administration, didn't really do very much public health outreach. So for instance, there were no public education campaigns on television of why it was important to get vaccinated. So for instance, back in October, you didn't see any advertisements on TV saying, get ready for the vaccine, it's good, it's going to be good for everyone, and really doing these public health campaigns like you will have seen for smoking or drunk driving or all these other public health campaigns. There was nothing like that for COVID vaccination, which is a typical part of what you would expect for a public health campaign. So now I fully expect, with the new administration coming in, that there will actually be public health campaigns. And it's sort of like marketing, to get people motivated, to get them understanding that they can trust the vaccine. And that takes a while to develop all this stuff. You need to plan it, you need to execute it. It's a whole process, and that takes easily months to do. So right now there's so few vaccines available that the ones who want it are having a hard time getting it. But then within a few months, let's say by spring, early summer, hopefully at that point, we're going to see a much bigger ramp up of public health campaigns just in the nick of time for people who had vaccine hesitancy to sort of be receivers of the marketing and the public health education campaigns, so that they too will want to get vaccinated. But it's definitely, because of the variation, we're definitely going to want to keep an eye on this. All right, next question.
Thank you, Harry. Great question. And Glenn, again, I'm sure you will be keeping an eye on this for us and letting us know over time how all of these different forces unfold. Okay, so let's talk more about the different vaccines. And could we review the common side effects from the second dose of the vaccine? How long do they last? And then maybe we can talk about, your thoughts on since they're, the rollout of the first vaccine is not going as quickly as we had hoped, would it be okay to delay that second dose? And would you rather more people get that first dose? What are your thoughts? So let's dig in deeper to the vaccines.
All right, so this is good, Rebecca, thank you. So the first part of the question, I talked about this a month or two ago, but hardly anyone had gotten the vaccine back then. So now I think a lot more people have gotten the first dose of the vaccine and are now wondering, how will the second dose compare? Because they've heard accurately that the second dose is more has more side effects than the first dose because your immune system has been primed with the first dose. So now the booster shot, you already have a minimum immune response, and so now you're going to, if your immune response has been good and it's been active, then you'd expect your body to respond and generate an immune response. So actually, the side effects are good. It means that the vaccine is working, and the booster shot can even make it even that much better. So basically, this is what was released in the emergency use authorization from Pfizer, and they're pretty similar across the different vaccines, and it's what you'd expect across all the new ones that are coming up too. Would probably be pretty similar, although I haven't seen the new data from Novavax or Novavax or Johnson and Johnson. But here's Pfizer, which is very similar to Moderna. Interestingly, people over the age of 55 tended to report less side effects than people under the age of 55. I'm not sure exactly why this is. I mean, one reason could be that in general, people over the age of 55 don't have as strong immune responses in general to things. And so it could just be consistent with that, is that as people get older, the immune system weakens in general a little bit. And so that could be what's explaining it. But I don't know exactly what's going on. But generally, as a group, people over the age of 55 are going to have less severe symptoms or less severe side effects from the vaccine. On the top here, we're looking at dose 1. On the bottom, we're looking at the second dose. All right, so the key thing here is the second dose. On the top, these are the types of side effects. You can see the key things that they've identified are these: fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, or joint pain. Just because I've said all these doesn't mean they're all equally common. You can see that by far the most common ones are fatigue. So just feeling tired within the next 24 hours or so, possibly 2 days, but for almost everyone, it all resolves within like a day or so. And so if you feel tired the day after, within the day of getting the vaccine, go and just take a nap. For some people, they've decided to take a vacation day or take a sick day the day following the vaccine, and then just take it easy that day and just take a nap and relax at home and just take it easy. So fatigue is something that's somewhat common. Around 51% of people reported fatigue after getting the second dose. Headache is also somewhat common. Roughly 40% of people report having a mild or moderate headache. A couple people report severe fatigue, and a couple people report severe headache. But it's not very common among as a percentage. Similarly, around 23% of people report chills after the second dose. All three of these things I've just mentioned existed to a degree after the first vaccine dose, but it occurs a lot more for the second dose. Also, muscle pain, both at the injection site, but also just generally malaise around the body is also sometimes experienced after the second dose. And finally, joint pain. Just their immune system is triggered. So some people experience, it's around 20%. So 1 in 5 people who get the second dose over the age of 55 will have joint pain. There are some others of these other things, but they really don't occur very much. You can see that diarrhea occurs roughly the same amount as placebo. So it's probably not really an artifact of the vaccine itself. The fever does occur with the second dose a little bit because the body believes that the vaccine is actually an infection. And so it generates a fever to try to control the infection. But it only occurs in around 10% of the people, 11% of the people. So it's really not very common. And again, it resolves within 24 hours. In contrast, among people under the age of 55, so among the group 16 to 55, you can see that there's a lot more of the severity and the frequency of these things. So for instance, for fatigue and headache in the under 55 age group, it's roughly 60% and 52%. 60% fatigue and 52% headache. That compares to 51 and 39%. So you can see that it is more, not a tremendous amount more, but a meaningful amount more in the under 55 crowd. Yeah, that's basically it. So when it comes to the side effects, that's what to expect. It's not exactly clear what we can expect with the new ones. Johnson & Johnson doesn't have its emergency use authorization yet. It's just applied to it. In fact, I can tell you what the early reports are of that they've released so far. I haven't seen a detailed description yet, just summaries by press release. And I hate evaluating things by press release because it makes it really hard to critically evaluate it. But basically, Johnson & Johnson reported that their vaccine is owned. One of the really cool things about the J&J vaccine, there's two really cool things. One is that it only is one dose. So whereas the Moderna and the Pfizer vaccine are 2 doses, J&J vaccine is only 1 dose. So that means you don't have to worry about people forgetting to come back for their second shot. It makes it much easier logistically. So that's the first thing. Second thing that's interesting is that it doesn't have to be stored at such really cold temperatures. You'll recall that because the Pfizer and Moderna vaccines are messenger RNA vaccines, they have to be kept at extremely cold temperatures because otherwise the RNA deteriorates. In contrast, this is uses the adenovirus. And so the adenovirus doesn't have to be kept at cold temperatures. It can be kept above freezing. So that means that you can use currently very, very common refrigeration or freezers to store the vaccine. It doesn't require these ultra cold storage devices. Having said that, you can see when you look at how effective it is around the world, it's not quite effective in the clinical trial that's reporting out as what Moderna and Pfizer reported out. It's hard to compare this to Moderna and Pfizer. Whatever you read in the news, it's really tricky to compare these vaccines because the key variants that we've been talking about, the South Africa variant, the Brazil variant, that make the people resistant to the vaccine, they were not very common when Moderna and Pfizer did their clinical trials. So as a result, it was just easier to be successful for Pfizer and Moderna because there was hardly any resistance out there. Whereas now with J&J now having to vaccinate people in South Africa as part of their clinical trials, then that means the average effectiveness includes the weighted average of all the people around the world, including people who they vaccinated in South Africa and other people who had the resistant version. As a result, the key thing here now is to see how effective it's been in different parts of the world. And the J&J vaccine is 72% effective in the current strains in the United States, or the current variants in the United States, I should say. 66% effective in Latin America, so including Brazil. 57% effective in South Africa. And they found that that you reached the peak effectiveness by around 28 days. So we've been assuming 14 days after the vaccines for Moderna and for Pfizer, but in fact, the longer after the vaccine, but reaching the peak by around a month or so after, here it's 28 days, you actually continue to get more and more protection by around 28 days, you reach the peak. And so it's just unfortunate for J&J and all the new vaccines that are coming out that they are having to prove their effectiveness among the mutations and the variants that are resistant to all the vaccines. So it just is it is what it is. One thing that's really interesting here, Novavax, and I expect it's pretty similar to J&J, is we see wide variation in effectiveness depending on whether someone's HIV positive or HIV negative. So among South Africa, people who had the South Africa variant, it was around 50% effective in all people, 60% effective in HIV negative people. And that means that if the weighted average was 50%, that means that in HIV positive people, it was far less than 50% effective in them. And so there's dynamics going on that I don't really understand, but something that a lot of people are going to be paying attention to, because if this is something that we need to worry about with HIV, there might be other comorbidities or other chronic diseases that might also limit the effectiveness that we really need to be paying attention to. And so these are things that are currently being evaluated. That's it for now. We can see. So one other thing that I wanted to just point out here is that is this. So this idea that 57% efficacy in South Africa, that means that the South Africa variant is not completely immune to the vaccine, or the opposite of immune. It's still, the fact that 57% are still being are prevented in South Africa means that the current mutations and the current variant in South Africa are still susceptible. The worry is that it mutates even further and can break out more. 57% is good, but not excellent. And so that means that over time, even if 100% of the people were to get vaccinated, 50%, 57% could still get disease and could still be spreading it. And so that's a worry over time. And the mutations don't just stop, the mutations keep on going. And the more, we talked previously about evolution, replication, if it continues, which we see here, it's going to continue to replicate. Mutations are going to continue to happen. If there's selection, which is the third thing that has to do with evolution, if there's a selective pressure based on the vaccines, then that means it's going to force the evolution of the variants away from the vaccine, which is not helpful for us. But this is the same idea with antibiotic resistance. And anytime you're looking at evolution in microbiology, over time, if you put a selective pressure like a vaccine on something, the virus is really smart. Even though it doesn't have a brain, evolution is much smarter than we are, and it tries any way that it can to escape from the pressure and the selective pressure of the vaccine. So that's what we can expect. All right, I think I've answered all those questions.
Yes, maybe. So we're at the hour together. Maybe we can wrap up with next. Well, let's see. We'll wrap up with, since it's Super Bowl Sunday, this is a good one to wrap up with the Super Bowl Sunday question. And maybe next week we can begin with kind of the philosophical question of, if we have a limited number of vaccines and the distribution has constraints on it, would you prefer to see more people get the first shot, or more people to then go ahead and get their second shot and stay on that schedule? So let's begin with that question next week, and instead let's wrap up with this NFL question, since it is Super Bowl Sunday.
Yeah, Rebecca, let's do both. It's not going to take much time, but let me do the Super Bowl, and then I can just spend a couple minutes on the last question, because I think it's a really interesting and timely question. But first, let's jump into the Super Bowl. It's on a lot of people's minds right now, so let's talk about it. So what has the NFL done? Some people might be really curious, because everyone's been worried about kids in school playing sports and other people playing professional sports. We're in the middle of an epidemic. What's going on with the National Football League? How much spread is going on there? All right, so the NFL has had over 700 coronavirus positives. False positives have been ruled out there, so they've been double tested. These are cases that they've identified. Interestingly, a single team has sort of won the competition. So if there's the Super Bowl in terms of who's winning the football game, that's one competition. But in who's winning the epidemic competition, the Seahawks have clearly won, because every other team in the NFL has had at least one case of SARS-CoV-2. The Seahawks has had none, based on their precautions, which is great. So in my eyes, as an epidemiologist, the Seahawks have won, even though they're not really competing in terms of, I guess, in terms of what we're looking at. Anyway, in terms of the football. First, so let's look at what they've done. So they've done a lot of things. They've changed the structural, the structures that they had. They've done a lot of reconstruction to install dividers and showers, to expand their meeting rooms. So the meeting rooms that they used to meet in were small. Now they've converted practice fields and large rooms into meeting rooms. They could be very far away. They've replaced windows that were just there for decorative, just as a glass, to ones that could be fully open, so that they had a lot of airflow throughout the whole facility. Ventilation systems were upgraded. They've had a lot of dining. Instead of having dining rooms where they would go and eat in the dining rooms, it's all been order in throughout the whole epidemic. They've done a lot of other things. A couple of things that struck me as really being the most interesting. And so I'll point those out. The two that I thought were most interesting is they all had to wear a device created by this company, Connexin. And what the Connexin device did is that it monitored every player who wore this. All the staff and players had to wear this device. And anytime they were within 6 feet of another person wearing the device, so all the staff or the players, anytime they were within 6 feet of another person for more than 5 minutes, 10 minutes, or 15 minutes, the device would beep and let them know. And so that means they were able to keep careful track of all the players and staff and make sure. And so it would constantly chime, and it would keep them moving to make sure they were not in contact. And so that was really cool. They had found in some of the teams that the 15-minute rule was not strong enough, that there were multiple examples of players and coaches who got infected in less than 15 minutes with other team members when they were not in well-ventilated places. And so even a short period of time might be too much if it's not well ventilated. So one of the things that they did was make sure that it's ventilated as much as possible, spend as much time outdoors as possible, and having these devices really worked well. They also made it into a competition to try to reduce the number of people that were within within close proximity as much as possible. The other thing really interesting that the league did was they fined people to ensure that people were vigilant. So, for instance, Carol, who is one of the coaches, was fined $100,000, and the Seahawks were fined $250,000 for not wearing his face mask properly, because his face mask was going below his chin rather than over his mouth and nose. That's a significant amount of money to fine people to ensure that they are compliant with mask wearing. So they really worked hard, because when we talk about the NFL, this is big money, and there's a lot to lose if there's outbreaks and people. One of the things that we've talked about previously is long COVID, and so if 10% of people who get a COVID infection or get COVID, if 10% of them go on to develop long COVID with fatigue and pain and headache and these long-term symptoms, that's a major problem for these players potentially, because that could really impact their careers and their total lifetime earning potential based on developing chronic COVID. So they had to really put some bite into these precautions. So there's some interesting things that they've done. That's enough for the NFL. I'll pivot quickly back to this question. Is it better to get one dose now for everyone, or to do 2 doses? And so it's interesting. There's going to be 2 different answers depending on who you ask. And this is an interesting idea, because typically epidemiologists will have one type of answer, whereas a physician treating patients will have a different type of answer. So let me just tell you real quickly what the difference is here. And so this I brought was an opinion piece published in the New York Times. Definitely you can see based on their opinion that these 2 people were physicians, not epidemiologists, treating infectious disease. Their point was, well, if the first dose of Moderna and the Pfizer vaccine reduces severe disease by 50%, and the second dose reduces severe disease by 95%, why not do 1 dose for the greater number of patients, and then you dramatically reduce the total number of severe symptoms and hospitalizations among the greater many? And the reason that physicians say that is when they look at their personal practice and the patients in their practice, their goal is to help everyone as fast as they possibly can. And so they're thinking only about the symptoms of their patients. They're looking with blinders on, only at the patients in front of them. And so it does make sense from that perspective to treat only 1 dose for those patients from a physician's blinders when they're looking at only their own patient population. The problem with this, there's 2 problems. First, it hasn't been studied. The studies that have taken place with the emergency use authorization and the clinical trials were a 2-dose regimen. So we don't have a good sense of the persistence and other important aspects of having only 1 dose. The second major problem from an epidemiologist goes back to evolution. And the problem is that when you have 2 doses, let me see if I can get this graph really picture, because it really points out what I'm trying to say here. Just give me 1 second, because it's so important. All right, it is over here, coming up. Here it is. All right, so my point here is when you have the first dose, The first dose is the first arrow in each of these cases. So the first dose here, second dose, first dose, second dose, first dose. And these are all different age groups. This is over the age of 70, 56 to 70, and 18 to 50. What you can see, I'll do the middle one because it's the clearest. The first dose produces a small amount of neutralizing antibodies. Even though it has a 50% reduction in how severe the symptoms are, it only has a minimal reduction in neutralizing antibodies. So that means that you'd expect it only has a small reduction in how contagious a person is if they get infected again. The second dose dramatically increases the neutralizing antibodies, regardless of the age, dramatically increases the neutralizing antibodies and prevents the spread. So the primary problem with 1 dose versus 2 dose in this regimen, it's not going to be the same for the Johnson & Johnson dose, which was identified as a 1 dose drug. But in the 2 dose regimen, the problem is that when you have 2 doses, it prevents breakout. And so if you have a strong, it's exactly the same concept of antibiotic resistance. That if you have a really, really powerful antibiotic and you knock it out, then you eliminate the risk of breakout and developing antibiotic resistance. It's the same thing here. If you have a really, really powerful vaccine and you eliminate the breakout, then you have much, much less risk of variants that can develop, mutations that develop that break out. In contrast, if a doctor were to say, well, we only have a limited amount of antibiotics, we should do half the dose for all the people, then the problem is, yes, you're going to reduce the symptoms in a lot more people, but you dramatically increase the risk of antibiotic resistance if you're to half the dose of antibiotics. And it's the identical issue here with vaccines. If you half the dose and only give the first vaccine and not the second dose, then you dramatically increase the risk of mutation breakout. And then it's bad for everyone if you have a further outbreak where the vaccines don't work again, because then you have to start from square one all over again. So going back to this central question, should we do 1 dose or 2 dose? It's really interesting. I think it's fascinating that you get 2 different answers depending on whether you're talking to a physician that treats patients versus an epidemiologist who looks at the epidemic as a whole. Because we're in an epidemic, it's probably better to listen to the epidemiologist because we're looking at the spread and we're looking at the population as a whole and want to prevent the spread, rather than physicians who are only looking with blinders on at their very specific patients in their own practice. So anyway, that's my conclusion for today.
Oh, interesting. Well, we'll take it. Fascinating. Fascinating. You've taken us through a lot, through the different mutations, you've explained to us again, the variations, the variants, the strains. You've taken us through a lot. That's so interesting what we've learned about the Seahawks. Too bad they are not in the Super Bowl, but I agree with you. They are definitely the winners for sure. So I'd like to leave with one very important question. Since you are a numbers guy, heads or tails, what's it going to be for today's game? What's your prediction?
The answer is 42. Do you know what that answer is? That's the answer to in the Hitchhiker's Guide to the Universe, the book. They ask the question, what is the answer to the life universe and the meaning of life and everything in the universe? And the answer is 42. So whenever you don't know the answer,
no,
just say 42 and answer
I'm not
everything.
letting you leave with that answer. Make a prediction. Come on, our conversations are all about predictions, and you're a numbers guy, so give us a prediction. What's it going to be?
I can't.
Heads or tails?
One of the sources of value of an epidemiologist is to know our value and know what we can predict and say it with confidence. And things we have no confidence in answering, we say, nope, it's outside of the scope and I cannot answer that.
Okay, fine. Hats off to you.
What do you believe? What is your prediction?
Well, I understand. I understand there's a special kind of coin that's being used today that may be a little bit more heavily weighted on the head side, which will then lead it to more frequently fall on the tail side.
Huh.
That's my limited understanding. So I'm going to go with tails. Anyone else going to go with tails? Raise show of hands. Anyone else going with heads?
Don't know.
Anyone not wanting to make a prediction? It's okay too.
Me- No prediction here.
All right. Well, we covered a lot. Star Wars. I've taken us totally off base, but now back again. Thank you, Glenn, for all you do always. Everybody be safe, be well, have a good week. And we look forward to seeing you back at the usual time. Yes, next Sunday, 7 p.m. Eastern time. All right. Take care, everybody.
Thanks, Rebecca. Thanks, everyone. Have a great week. Bye-bye.
You too. Bye-bye.